So my name is Gavin Giovannoni. I'm a professor of neurology at Barts in the London School of Medicine and Dentistry. I'm based in the East End of London. We have two main hospitals linked to our medical school at St Bartholomew's, Barts Hospital, and the Royal London Hospital. The neurology unit is mainly based at the Royal London. So, most people just break up MS into two clinical subtypes, what we call relapse or attack onset MS, and then the primary progressive type. Primary progressive is about 10 to 15%. In some parts of the world it's a bit higher than that, but on average it's about 15%. They present with a progressive course from the beginning, no discernible relapses. Whereas the attack onset one, you get usually a sentinel attack, and then you go on to have more attacks, and then after a variable period of time, you enter what we call the secondary progressive phase of the disease, where you get this progression independent of relapses. Now, there's a grey zone between those transitions, because you can still go on to have attacks, even though you're in the progressive phase of the disease, but the attack frequency goes down. In the natural history studies, 80% of people with an attack onset disease would go on to develop secondary progressive. In other words, only 1 in 5 wouldn't. We'd call them, we'd say they have a benign course. But invariably, most people would end up in the progressive phase. Now, with disease-modifying therapies, we think this is changing. All the data sets suggest that we, at least in the injectable first-line therapies, we are delaying the onset of the secondary progressive. With more effective therapies, we may be preventing it in some patients. We just don't have enough data to say that with certainty. I'm quite cynical of this whole clinical classification, because clinical phenotypes are, prior to disease-modifying therapies, we used to diagnose the onset of progression with an EDSS, long before physical disability was at about 2. And that was done on history. Somebody would come in and say, I went for a 5-mile walk and my foot started dropping. And you say, well, that's a bit worrying. And then they come in the next time and say, well, my foot now drops after 1 mile. When you examine them, nothing's changed in the examination, but the history would say, well, they've probably got the progressive phase of the illness. This is what George Reevers did in the London Ontario data. So you do a retrospective classification. As soon as disease-modifying therapies came along, as soon as you called somebody progressive, it affected insurance reimbursement. So you would never call them secondary progressive. You'd say they had relapsing disease. So the average EDSS score now for diagnosing secondary progressive MS is 4, 4.5, and even higher, based on reimbursement. So we just manipulated the definition, depending on what the needs are. I actually think the progressive phase of the disease is there all along, because the pathological substrate is essentially a neuroaxonal loss, and we've seen brain atrophy right from the very beginning of this disease. But the reason why it doesn't manifest is because the brain's got reserve. So, while you've got reserve capacity, you compensate for the loss of neurons, and then at a point in time you can't compensate. That's when it becomes clinically apparent. But the process is there all along from the very beginning. So I actually think this idea that there's a defined point in time is a quirk of phenotypes, and it doesn't really apply to the pathology of the disease. I think the process is there from the beginning. Very difficult to apply, and also doing it properly takes time. Particularly low end, it's an impairment scale, so you have to examine patients in detail, and then you score them on the scoring sheet and give them a score. And to do an EDSS well, you also have to walk patients 500 meters at least. So so for the average neurologist to do an EDSS, he just hasn't got time in a consultation. So we're not doing them properly. As far as psychometrics go, the EDSS is a shocking scale. It's got high rate inter and intra-rating variability. It's got ceiling and floor effects. It varies from morning to afternoon. Lots of issues with it. So if we had to start from scratch, we wouldn't have the EDSS. We'd have something else. But unfortunately, all our natural history data and most of the trial data is based on the EDSS, so it's not going to go away. It's probably going to stay. It's what I call the flawed gold standard.
Tell us a little bit about that.
Well, the regulators now, particularly the FDA and the European Medicine Agency, they've got used to the EDSS, so they know how to interpret trials and make comparisons with it. And it may be okay for licensing of drugs because it's quite a crude scale, so any meaningful change means something. But in terms of using it in clinical practice is very, very difficult. Okay. So we definitely need more subtle scales. It doesn't capture, one of the most important domains is cognitive impairment. The cognitive scale in the EDSS is worthless, absolutely worthless. So if you want to talk to people about cognitive impairment and all that, you can't use the EDSS, you have to use other scales. So, there is a big task force going on at the moment to try and use other scales that capture the impact of the disease on the individual's life more, and I think it'll gradually creep in and take over. And MRI brings us closer, but even MRI, particularly looking for focal pathology, that's the lesions that come and go, the resolution there is about 3 or 4 millimeters, and it also depends on the type of scanner and whether or not you use gadolinium enhancement to pick up lesions. So the brain atrophy is a lovely story because it's kind of an integrator. I call it the integrator of what's happening in terms of end organ damage. So when you see this accelerated brain atrophy occurring, it's got to be bad, and we know it's bad for you because it correlates with so many outcome measures now in terms of, and also quality of life, that we really have to address that issue. Now, one of the problems we have with disease-modifying therapies is that when you put people on disease-modifying therapies, you get pseudoatrophy, you switch off the inflammation, so you get this acute shrinkage. So if we're going to use MRI in clinical practice, we have to re-baseline after the drug's working and we get rid of that pseudoatrophy effect. So most of us, for logistics reasons, are doing a rebaselining scan 6 or 12 months after starting a therapy, and then we measure. In our centre, we do annual scans, and that's becoming our norm now. We make decisions not only on clinical criteria but MRI criteria as well. No, the trend is probably worldwide in terms of focal pathology, new T2 or enhancing lesions. In terms of brain atrophy, it's just catching on. And the reason for that is that there's still lots of variability in terms of the measurement. Implementing brain atrophy measurements on routine scanners is not universal. So there are now software platforms. You just upload the images and they send you down the atrophy measurements, which are beginning to be implemented. I was just in a meeting in Australia, and there's a centre in Australia that does brain atrophy measurements for any centre in the country who wants to send them the scans. So we're beginning to see brain atrophy creeping into clinical practice. Well, I think it should. The measurement error is really an issue around short-term changes. So when you start seeing brain atrophy occurring over 2, 3, 4 year time windows, it really means something. And if I had MS, I wouldn't want my brain to be shrinking faster than it should, particularly now that we've got therapies that impact on brain atrophy. In terms of the monitoring, I think what we need to do is adopt what happens in rheumatology, this concept of a treat to a defined target. And so we define, there's this term NEDA, which we've stolen from oncology. It's called NED in oncology, no evident detectable disease. We call it no evident disease activity. And we've done that deliberately because we can change definition with time as new technologies come along. So our current goal is to switch your clinical activity, no relapses, no progression, and no focal MRI activity. And we're going to add brain atrophy to that. I think another metric we may add is CSF neurofilament levels. Neurofilament levels are a biomarker of axonal degeneration. So in some countries, in Sweden, for example, they've got routine lumbar punctures. The spinal tap, measure the neurofilament levels. If they're high, there's ongoing damage, they'll switch therapies based on that. So they're really early adopters. So I see that catching on. In terms of therapies, well, at the end of the day, we just need to get more effective therapies that are safer. We've got very effective therapies, I think, but they come with risks. And so the next generation of therapies are going to have to be in the same efficacy zone, but safer. That's all. And then the unmet need is progressive MS. So we can't really stop the progressive disease purely with anti-inflammatory drugs. So the next phase will be add-on combination therapy strategies, and we evidence-free zone. We need to do the trials. So I was just at a meeting this morning where we were discussing a combination therapy trial. What can we add on to an existing disease-modifying therapy to slow down the progressive phase or the neuroaxonal loss? So that's where we're going, which is what happens in a lot of other diseases. I mean, cancer therapies are combination therapies. Even in rheumatology, combination therapies. Transplant rejection, combination therapies. It's not like you're going to tackle all the components of the pathology with the monotherapy. It just doesn't make any sense. And at this, well, I should say it, at this American Academy meeting, they're going to present the negative fingolimod trial results in PPMS. And that's an example of an anti-inflammatory drug not having an impact on the primary progressive phase. And I think what probably was needed is fingolimod plus something on top of fingolimod. No, it'll get there. It's just that the outcomes, we don't have really surrogates. I wish we did have surrogates. So rheumatologists have got surrogates. They use subchondral erosions as their marker of end organ damage. Or if the FDA and the European Medicine Agency allowed us to use brain atrophy rather than clinically disability progression, then we would get these drugs very quickly, because I think brain atrophy may become a surrogate in the future, over a 2 or 3 year period. If we can show that we've normalized brain atrophy rates and normalized CSF neurofilament level, in other words, impacting on the pathology, maybe we could get drugs licensed, at least at an initial phase, to get people onto the treatments and then provide the clinical outcomes, because the clinical outcomes are lagging way behind the MRI outcomes. So we'll see the clinical outcomes emerge over 4 or 5 years in progressive MS. That's how long it takes to have an impact on the course of the disease. So we need to lobby regulators to change their what they accept as a surrogate endpoint, because we don't have any surrogate endpoints in MS, unfortunately.